Welcome to Project 31 YouTube channel. We are so glad you're here today. This is Jennifer Harrod. She's our nurse navigator, and I'm Jane Wilson. We're glad you're here. We're going to talk about HER2.
Yes.
Jennifer's going to tell us all we want to know about HER2.
Yes, pretty much what it means when you get the diagnosis that you're HER2 positive and what next.
So let's start with, what is HER2? What does that even mean?
Sure. So I think a lot of people, when they get diagnosed, they're going to hear your ER, PR, positive or negative, estrogen receptor, progesterone receptor. Then you hear HER2. So HER2 simply means that it's called hormone or human epidermal growth factor receptor 2. Hence why I had to look down at it, because that's a mouthful.
That's why they call it HER2.
It's a mouthful. So human epidermal growth factor receptor 2. So it's simply a protein that is found on the surface of the cells, and it's involved in normal cell growth. When HER2 amounts are elevated, then it causes the cells to grow and divide. Breast cancers that have too many HER2 receptors are called HER2 positive. It can also be called, you may hear them say, HER2 overexpression or amplification.
That's what mine said.
So, yes, so there's different terms, but they mean the same thing.
They mean HER2 positive.
Exactly.
Right?
So once the doctors have informed you that you're HER2 positive, you may wonder, okay, what's going to happen now? What's the next treatment? What's going to be involved? But really, the main thing, there's going to be a hurry up and wait a lot of times, as we all know, as we all have experienced, waiting on the HER2 test to come back. And the doctors really have to have this information. And I like to think of it as a puzzle and a piece of the puzzle. Because in order to really treat you properly, in order to address your specific cancer, they have to have all the pieces of the puzzle. So the worst part is really waiting on all the tests, waiting on all the scans, waiting on all the lab results to come back. I know that's stressful for a lot of people.
So whether you're estrogen positive, progesterone positive, HER2 positive, or negative in all three of those examples, you can be positive on some and negative on others. You can be all positive, you can be all negative, right? That'll drive like the course of chemo or whatever that they're suggesting for you, right?
Right, the course of your treatment and what it involves and what it entails.
How aggressive they need to treat it.
Right.
Whether or not estrogen suppressors are needed at some point, those kinds of things, right?
Exactly. Also, whether you're going to start off with chemotherapy first or maybe after surgery.
Okay.
There's two tests that you'll often hear mentioned whenever they're testing for HER2. That's going to be the immunohistochemistry, also called IHC. I will call it IHC from here on out because I'm not going to say that mouthful.
Right.
The other one is fluorescence in situ hybridization.
I've never even heard of that.
FISH.
Okay, there you go.
So IHC and FISH, those are the two tests that you're really going to hear whenever your doctors are talking about your lab tests.
Okay.
IHC is the most common one you're going to hear. The results are given as a 0 to a 3+. 0 to 1+ means that you're HER2 negative, okay? If the results are HER2 a 2+ on your IHC, then that means that it does show some cancer cells that are HER2, but not enough to consider it positive or negative. Further testing is required. You often hear this called equivocal. 3+ on your IHC means that you are HER2 positive, overexpression amplification. So if your IHC comes back as a 2+ or equivocal, then another lab test will often be run, and that will be the FISH. So the big long word, FISH. And They normally will take the original biopsy specimen that you had and they'll run the FISH. The test results for the HER2 gene amplification will just mean that there's lots of HER2. The FISH results are often more accurate than your IHC results, but the test is more expensive, takes longer to run, and that's why they're going to start with the IHC.
Because if they get a clear indication with that, then they don't need to do the second test.
Exactly.
Okay.
If you come back as a 0, a 1 plus, you're HER2 negative,
We're done.
we don't need to do any further testing.
Okay.
If you come back as a 3 plus, we don't need to do any further testing.
In that middle.
If you're that 2 plus, that equivocal, then normally they're going to want to do some additional testing.
And is HER2 specific only to breast cancer? Or does it have implications in other
It
kinds
could
of
have
cancers too?
implications in other cancers, but we mainly...
For sure, it's breast cancer test that's going to be run every time.
Exactly. Okay. Yeah, that's what they're going to be interested in.
ER, HER2, always.
Those are what they're going to look for. Now, what's interesting is they did not run a HER2 on me because I was DCIS.
Okay.
So mine was ductal carcinoma in situ. So they did ER, but not HER2 because the HER2 wouldn't
apply.
To
because
me.
it hadn't moved.
Right.
But mine it was in my lymph nodes. It had infiltrated my lymph nodes. So they tested for all of that for me.
Yeah. And some people, they do test for HER2 even if you're DCIS.
No matter.
So it just goes to depending on your oncologist.
Yeah, I can see that. And what their protocol, what they feel comfortable, the battery of tests that they feel comfortable reviewing.
Right, right. So HER2 positive breast cancers they can grow quicker than other breast cancers. They can also carry, if you're HER2 positive, they can also sometimes carry a poor prognosis. But nowadays, with the HER2 diagnosis, survivors have better outcomes because there's now targeted therapy. So it's a lot better outcomes than there used to be. HER2 targeted therapies can involve HER2 antibodies. They prevent growth signals from HER2 outside of the cell, so outside of that cancer cell, and they increase the attack of the immune cells on the cancer cells.
It's kind of a double whammy.
Right. Then there's HER2 inhibitors.
Okay.
So just like you think about, they stop the growth signals from the HER2 from within the cell. So they're inhibiting, they're blocking. Okay. The HER2 conjugates, or antibody drug conjugates, as you might hear, deliver a cell-specific chemotherapy. So they attach themselves to the HER2 and they enter the cell. So then, once inside the cell, they're going to release that chemotherapy. So I kind of picture it, probably not accurate, but I picture it kind of as a chemo bomb. I'm going to hook to the HER2 and I'm going to travel inside that cell and explode it with the chemotherapy. But just as we've talked about before, each breast cancer journey is different. So your treatment may look different than the next person that's HER2 positive. They're all different. Most HER2 positive early breast cancer treatment starts with HER2 targeted therapy in combination with a chemotherapy, but may also be given alone or possibly in combination with endocrine treatment if you're hormone positive. And in some cases, doctors may recommend starting with surgery first, followed by the treatment. Treatment after surgery is called adjuvant treatment. Starting with chemotherapy before your surgery is called neoadjuvant. So there's different ways. Neoadjuvant therapy is often used to shrink the tumor prior to your surgery.
And that's just going to depend on what your oncologist feels good about, right?
Completely.
How quickly is this thing growing?
How large is it to begin with?
Yeah. Where did we start? Right.
So it's completely up to your medical oncologist on what is the best treatment for you.
And they'll work with your surgeon to coordinate all that. Because you wouldn't want to start chemo, then have surgery, then finish chemo. Almost nobody tries to do that on purpose, right?
Right. A lot of times if
It
you're HER2
happens.
positive, they may do, 3 or 4 treatments,
Right.
then do surgery and then complete the rest
To kind
it
of
at the
shrink it
end.
a little bit. Yeah. No, I've heard of that where they
Right.
definitely are trying to shrink it. And that makes sense because it's just less invasive surgery.
Right. And get that medication on
Get it going.
Exactly. Expect that you will have screening of your heart prior to starting treatment. This can either be an echocardiogram or a MUGA, and your doctor will monitor.
I haven't heard of that.
Yeah, and I'm not going to get into
Okay.
that part of it.
No, but that's like it's some sort of heart
It's, yes, it
echocardiogram
monitors,
type
yeah,
thing.
it monitors
Okay.
your heart
'Cause
as well.
a lot of
and
us have had
ultrasound.
EKGs.
Yes, and an echocardiogram or MUGA. Your doctor will monitor your heart function while you're on the medications. Normally, they're going to do it every 3 months, and then they'll also follow you after treatment is completed. Also expect that your oncologist may offer a port, and that's simply a medical device. The port is placed under the skin,
Right here.
normally in your chest. It's placed into a large vein and allows intravenous access. A port helps to protect your veins from damage from continuous access during your cancer treatment and from those just really harsh drugs.
Yes, and I had a port, and I was thankful that I did because my dad didn't have a port, and it was difficult. He had challenges. He had lung cancer, and he had some, a lot of vein issues, and just so it's if they offer you a port, you definitely should consider it. Yeah, it is a blessing.
Mm-hmm. And your port may raise your skin just about a ½ inch or so, and you may be able to feel it, but other people normally can't see it.
It wasn't irritating, and I could cover it with all but just the lowest cut things. I mean, like normal clothing hit it, no problem at all.
So it's more obvious, I think, to you. You see it more so than other people, but definitely a blessing to have.
Oh, for sure. Yeah, it makes life a lot easier on chemo day.
2 common medications that are often used for HER2-positive breast cancer are common ones that we hear is Perjeta and Herceptin. So there's also trastuzumab biosimilars that are now out there as well. And there's other medications that may be utilized during your treatment depending on your specific cancer diagnosis. Some of these HER2-targeted therapies are Kadcyla in HER2, Tykerb, Margenza, Nerlynx, Turquesa, and Phesgo.
And are all these IV drugs?
Some are actually
Oral?
pills
Okay.
and oral. Some are even an injection that they may give you.
Okay.
So depends on the medication. And I know I probably slaughtered some of those, but I got as close as I could. Your medical oncologist will tell you which is best for you for your cancer, your diagnosis. And keep in mind the options here are just some of the treatments that you may be eligible for. This list does not include all possible treatments, and your doctor may recommend something different. So,
And I'm sure they're coming out with new stuff all the time, every day.
goodness,
It
they
seems
are.
like.
And that's why some of these I can't pronounce
Of
because
course
they're
not,
brand
'cause
new
they're
ones.
brand new.
So often this neoadjuvant treatment is then followed by surgery and possibly by radiation. And after surgery, most HER2 patients will be given adjuvant targeted therapy. And I know a lot of people wonder, why are you going to give me treatment after my surgery? Why do I need this adjuvant treatment? And the answer is to kill the remaining cancer cells and to lower your chance of cancer returning.
That's how they explained it to me. They said, we took the tumor out, we got the main thing, but we want to sweep your body and get all the crumbs, get all the little, just did it go down to your big toe? Like we want to get them all, whatever little corner of your body they're hiding in, get them all out of there and kill them all.
Definitely.
And so I was like, okay, the sweeping analogy made sense to me. They were like, we made the first pass, we got the big stuff. Now we're going back after the little stuff.
Get those little crumbs. And we want that. We want to, yes, we've taken the tumor out, but let's give our bodies a fighting chance. So
yeah, for real.
So I do want to, the oncology nurses are lifesavers while you're going through this. They can help you with referrals. So if you need a referral of, maybe a counselor, maybe physical therapy, a nutritionalist, or any side effects that you need to address, because we all know there's side effects from certain medications.
If you're not sleeping, if you're nauseous, just all the
Diarrhea, constipation.
all those things.
Yeah. And I just encourage you, no matter how small that side effect you think it may be, why live with it if there's something that can be done for it?
Yeah, bother them. That's why they're there.
Yeah, that's
right?
their
That's their
job.
job. They want to take care of you. They really care about your well-being, not
do.
just getting the cancer out. They care about, how are you, because if you're not doing well during treatment,
Right.
they don't like that. They're not happy about that. They want you to thrive during treatment if at all possible, to be as well as you can be, right?
Definitely. And they can't help you if they don't know.
No, if you don't call them.
Yeah, they just don't know, and they want to help you. And also the infusion nurses, they are a wealth of knowledge. They can help give you tips to make your treatment go smoother because they see it. They work with it every day, day in, day out.
They recognize it before we do often.
Yes. So definitely talk to them as well. Make that relationship with them. But one of the most important things to remember is you're not alone.
Right.
There is help for your struggles that you're going through at this time, but you must inform your oncology team. That communication is vital.
It's vital. It's essential. Because without it, they're just trying to, they know what to do about the tumor, but you're the whole person too, right? That's the thing.
It is. And so much of the time, some of the doctors will just look at your cancer.
Just the tumor.
Because that's what they're focused on, but your nurses are looking at the whole.
Yeah.
So they need to be who you're communicating with. And be sure to discuss all of your options with your doctor. And remember, only your doctor and healthcare team can give you medical advice about your disease and treatment.
Right.
You're going to read a lot out there on the web. You're going to talk to a lot of other people that have gone through breast cancer, and they come out of the woodwork.
They do. And I know, my experience will not be the same experience that someone's having today, because my experience was many years ago.
Yes.
And things change over time. Things change not even just over time,
Rapidly.
they change rapidly from year to year. I remember it hasn't been that long ago that the protocol was always surgery first. Well, that's not always the protocol anymore.
Right.
And often it's surgery last.
Yeah.
I feel like a big percentage of it. So things change. They get more information. They have better drugs. They have better whatever. And just because that was my experience doesn't mean that's going to be anyone else's.
So, make a list of questions, talk to your doctors, ask them, and go by what they suggest and their recommendations.
They're staying on top of it. They're seeing all the new drugs. They're going to all the conferences. They're reading all the literature. That's their job. They stay on top of what the new things are that are coming out to help you. And so just because your mom or your grandma did it this way, or your sister even 5 years ago, right?
Right.
May not be the same options for you.
Exactly. So hopefully this has answered some basic questions, maybe even more than you want to know.
It may have caused you to have more questions. If that's okay, that's okay. If you want to email us at info@project31.com, we'll be happy to answer questions. That's why we're here. Jennifer's great at it. So thanks for joining us today. Hit the thumbs up, subscribe to our channel, and we'd love to have you back here next time.